This section is a crucial one for you to understand as you transition into your wards experience and also as you try to learn the next 2 pages of first aid. This guide attempts to explain the difference between seemingly similar dermatologic terms. Some examples have been provided here to help you with this. Let's start by talking about the first 4. A macule is simply a flat discoloration of the skin that is less than 1 centimeter in diameter. If, however, the discoloration were greater than 1 centimeter, it would be referred to as a patch. Similarly, if the skin lesion were less than 1 centimeter but now it were elevated, it would be a papule. And if it were greater than 1 centimeter and elevated, it would be called a plaque. A classic example of a papule is a small pimple like you may find in typical acne. However, plaques are the most extensive skin lesions you'll see in patients with psoriasis. A vesicle classically is just a smaller fluid-filled blister like you would see in chickenpox. If it were bigger, it would be called bullae, singular bulla. But the terminology distinction is a bit vague here. If the blister were filled with pus, it would be called a pustule. If any of these were to pop and then dry over, it would form what's called a crust. This is a common finding described in impetigo, which we'll discuss later. A wheal is a vesicle that appears transiently, usually for some reaction, like hives. A keloid is different altogether, and is an area of scar tissue, hypertrophy, that has become raised following a trauma to the skin. It is most common in black patients. This list contains terms related to the architecture of the skin when you look at it with a microscope. If you remember the image of the 5 layers of the skin, remember the mnemonic Californians like girls in string bikinis to remember the names of the layers. We'll see now how different pathologies will have classic findings on histology that affect the diagram of the skin. In diseases like psoriasis, a common finding is the thickening of the stratum corneum, which is the topmost layer. This thickening is called hyperkeratosis. If the nuclei of the cells in the stratum corneum still had nuclei, it would be called parakeratosis. In other diseases, parts of the epidermis can increase in number, particularly the spinosum layer, and create what's called acanthosis. If this same layer splits apart, as occurs in other blistering diseases, it is called acantholysis. General inflammation of the skin is referred to as simply dermatitis.
Okay, so now we start a big section, the section on skin disorders. You'll notice that the description for each of these is pretty short, but most of the information is very high yield, and when appropriate, actually tells you exactly what a board-style question might ask of you. There are 5 classes of skin disorders that we're going to discuss, the first of which is just the common ones you may see. Then there are disorders of pigmentation, infectious disorders, blistering disorders, and finally a group of miscellaneous disorders. Let's start at the top with the common disorders. The first of these is verrucae, a complicated word to describe simple warts, which you may have already seen. These are soft, tan-colored, and cauliflower-like. If you look at them under microscopy, they appear to show epidermal hyperplasia or hyperkeratosis, as well as chelocytosis. There are many different types of warts, from the commonest form, verruca vulgaris, that might appear on the hands, to condyloma acuminatum, which can appear in the anus or on the genitals. The latter is known to be caused by HPV types 6 and 11 commonly, not the types associated with cervical cancer. The second common skin lesion is the nevocellular nevus, which is simply a common mole. Urticaria is the term used to describe hives, which are in fact wheals that are very itchy secondary to release of inflammatory factors from mast cells. You can see these in a wide variety of allergic responses. Ephellus is the technical term for a simple freckle. It is important to know that freckles actually represent small areas of skin with the normal number of melanocytes, but actually have melanocytes that just produce excess melanin pigment. Atopic dermatitis is an important disease to know that you likely already know is more commonly called eczema. Eczema classically is itchy and occurs in many areas over the body, particularly the flexors of the extremities. Usually, atopic dermatitis is just one piece of a greater atopic triad, which includes allergic rhinitis and asthma. Atopic dermatitis is often compared to a different dermatitis called contact dermatitis. While you would expect atopic dermatitis to come on very quickly since it has some allergic and therefore IgE-mediated signaling, allergic contact dermatitis does not follow the same rule. Here, the skin changes result from a delayed type hypersensitivity reaction, or type 4 reaction, and may take some time to develop. The classic example of this dermatitis is the reaction people naturally have to poison ivy. If a patient comes in claiming to have contacted poison ivy only 30 minutes prior, and they now seemingly have a reaction on their skin, it is unlikely to be poison ivy, only because it takes a couple of days for the reaction to develop. This is another great example of how questions can be answered knowing chronology of diseases and rapidity of onset. Another common disease we've discussed to some degree is psoriasis. The classic lesion in psoriasis is multiple salmon-colored plaques with silver scale over them, particularly on the extensor surfaces of the extremities, i.e. the knees and elbows. Interestingly, when you look at the skin of these patients with microscopy, there is acanthosis, meaning an increased spinosum layer, parakeratosis, meaning nuclei retained in the corneum layer and a smaller granulosum layer. You should definitely memorize these findings, as their presence is usually a pretty big hint that the answer to a question is psoriasis. There are a few diagnostic clues that may help you to confirm a diagnosis of psoriasis in a patient who presents with a rash. The first is the Auspitz sign, which means that when scale on the lesion is scraped off, that spot will tend to bleed. The second clue that you might get is that psoriasis is a systemic disease that doesn't only affect the skin. As we've already discussed, there is a seronegative spondyloarthropathy associated with psoriasis called psoriatic arthritis, and patients may present with those symptoms first. The other association that exists is often nail disease, commonly described as nail pitting, but there can be a whole variety of disease manifestations. The final common skin lesion that we'll discuss is seborrheic keratosis. This is a flat, greasy, pigmented skin cell tumor that includes keratin-filled cysts and happens most commonly in older adults. It is classically described as looking like it was pasted on, but cannot be scraped off, and it can truly happen anywhere on the body. The only classic board-style question about this skin finding is that it can reveal an underlying disease. There is, for example, the sign of Lasar-Cholat, which manifests with the appearance of multiple seborrheic keratoses rapidly, indicating an underlying cancer, often of the GI system, usually gastric cancer. The next set of diseases we'll touch on are the diseases of pigmentation. There are 3 of them that we'll discuss here, but there are in fact many more. Others, like albinism, are general terms that describe a spectrum of diseases. One form of albinism is caused by a decreased function of the enzyme tyrosinase, a critical enzyme in the formation of melanin. If you look at their skin histologically, you should therefore expect to see the same number of melanocytes, but each melanocyte produces less melanin. A different form of albinism occurs as a result of poor migration of neural crest cells into the skin. In this form, the melanocytes, a neural crest cell derivative, never actually make it to the skin, and therefore a decreased number of melanocytes is the actual cause of the disease. What's another disease that results from the migration failure of neural crest cells? That's right, Hirschsprung's disease. A different disease entirely is called vitiligo. Here, the problem is more focal and usually not as generalized as in albinism. The main reason for the disease is because of a decrease in the number of melanocytes, usually as an acquired phenomenon, which means the neural crest cell derivatives made it to the skin and were working fine until some idiopathic insult caused them to be destroyed. As a fun side note, this is the disease that Michael Jackson claimed caused his progressive skin problems. A final skin pigmentation disorder is the one seen in pregnancy, which is called melasma, or the mask of pregnancy. You often will see this in patients with oral contraceptive pill use as well, indicating the role of hormones in this hyperpigmentation. The next 5 diseases are all types of infectious skin disorders. These are actually very boards relevant, particularly because the first 4 are caused by one of 2 bacteria, which can make for difficult diagnoses if you don't try to keep them straight. We'll try to provide the classic vignette associated with these 4. The first is impetigo, which is a very superficial skin infection, usually caused by either Staph aureus or Strep pyogenes. It is incredibly infectious. The classic location is on the face, likely on the chin, with some of the lesions rupturing, leaving a honey-colored crust on top. A virtually pathognomonic buzzword for you to remember. The second disease listed is a very common disease and is probably the start of a spectrum of diseases. Basically, you should think about cellulitis as an acute, painful, red-hot spreading infection of the dermis and subcutaneous tissues. The same bugs, Strep pyogenes and Staph aureus, are implicated here. There are a variety of others that may also appear given the right clinical scenario. For example, Pseudomonas is a common perpetrator if there is an underlying burn. While you should think of cellulitis as the start of a spectrum, the exact opposite end of that same spectrum of skin diseases is the most dreaded of them all, and that is necrotizing fasciitis, affectionately abbreviated to neck fash, a much deeper injury that is much more serious clinically. This can be caused by Strep pyogenes, but can also be caused by other flesh-eating anaerobic bacteria. The classic description is the finding of crepitus on physical exam, a type of crackling sound which is quite literally the sound made by rapidly moving bubbles of gas that is formed underneath the skin. This gas comes from the methane and carbon dioxide produced by the underlying infection. The clinical scenario will include either a post-surgical patient or a patient with a skin infection that appears to be worsening incredibly rapidly. There may be some blood-filled blisters that form quickly or a grey discharge from the surgical site. The next skin lesion is actually a syndrome called staphylococcal scalded skin syndrome. Here, an exotoxin that is released by Staph aureus destroys the attachments between the keratinocytes and the stratum granulosum. Patients develop a generalized erythematous rash with loss of the layers above the granulosum. Classically, this disease is thought to happen in newborns and children. Two things help confirm the diagnosis. First, you should expect that since this is a diffuse disease, there will be some systemic signs like fever. The second is that the disease should cover the body almost head to toe, and not just be in a focal position like you would expect if it truly was impetigo, cellulitis, or necrotizing fasciitis. The final infectious skin disorder we'll discuss is hairy leukoplakia, which classically appears in the mouth, even more commonly on the side of the tongue. The differential for white tongue lesions usually only includes leukoplakia versus thrush. The clinical distinction is made when you try to scrape it off. Thrush comes off, while leukoplakia doesn't, even though it may appear it should. This lesion occurs as a result of Epstein-Barr virus, and is often a sign of underlying immunocompromise, such as HIV or AIDS.